Hello everyone. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. My name is Autumn Cyphus. I am the project coordinator with the Canadian Coalition for Green Healthcare. And on behalf of the Coalition and Cascades, who is funded by Environment and Climate Change Canada, I would like to welcome you to today's webinar, Look Ma, No Gloves, Safely Addressing Unnecessary Glove Use. Throughout the webinar, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentations, and our panelists will be answering questions at the end of the webinar today. We are also recording this webinar, so the recording will be sent out to all registrants and attendees either today or tomorrow. And it will also be available on our website and on our YouTube channel. So to start off the webinar today, I would like to invite Sarah Machane, the Innovation Lead of Cascades, to introduce today's topic and speakers, as well as show you all how to turn on your closed captions if you're not familiar with this function. Take it away, Sarah.
Hello, everyone, and welcome to our first gloves webinar put together in collaboration with the Canadian Coalition for Green Healthcare and Cascades. So my name is Sarah Machane. I am the innovation lead for the province of Quebec for Cascades. So I'm quickly going to share my screen to show you that we have the option of captioning. So Zoom. Oops, just give a second. Here. Can you all see my screen? So you can speak in the language that you prefer. Zoom has the option of captioning. So you just have to go on the bottom side of your Zoom window and select your speaking language, and you'll have automatic translation in the language you prefer. So usually French or English. So as we know, quick word of introduction, as we know, glove use has a substantial environmental and health impact. So WHO report in 2022 revealed that out of the 87,000 tons of personal protective equipment they sent to hospitals over the first year of the pandemic, there was an estimation of 44% of unnecessary PPE. So there was an article published in 2023 by the Canadian Coalition for Green Healthcare. They undertook a project on promoting the reuse of personal protective equipment funded by Environment and Climate Change Canada. The weight of PPE measured from the three largest government purchasers of PPE in Canada, so the federal government, Quebec, and Ontario, revealed that gloves were the highest weights of all the PPE purchased, with disposable gowns the second largest amount. So in terms of greenhouse gases emissions, the GHG emissions of PPE measured from the same three largest government purchasers of PPE, federal, Quebec, and Ontario, they revealed that gloves were the second highest contributors to GHG emissions, and disposable gowns were first. So while reusable options exist for gowns, there are no reusable options for gloves. So there needs to be a concerted effort to explore safe reduction of glove use. And so, just a sec. Okay. So there are a lot of groundbreaking initiatives that are emerging to promote the appropriate use of gloves in healthcare settings. And today we're going to have three presentations, each of them showcasing an initiative from a different region. We have the United Kingdom with the National Health Service and GOSH, British Columbia at Fraser Health, and Quebec So I'm very happy and grateful to welcome our speakers to take a dive into their work today. We will have a little bit of time for questions at the end of the meeting, so please feel free to use the Q&A box so we can answer them all at the end of the meeting. So diving straight through it, our first speaker is Nicola Wilson from the NHS Foundation Trust. She has worked in several different hospitals, principally within pediatric neurosciences. Over the last decade, she has worked within education, becoming a qualified teacher, enjoying the practical aspects of this role, from facilitating, learning alongside with staff, and leading a team of educators across the trust. So thank you, Nicola, welcome, and over to you.
Hi there, thank you very much for having me. I'll just start by sharing my screen, so bear with me a second. I'll just pop that full screen. And I hope you can now see that full screen, and that's all okay. So as introduced, I'm Nicola Wilson. I work at a hospital called Great Ormond Street Hospital in London, in the United Kingdom. And this is the team of us that led this project at Great Ormond Street. So myself as a nurse and an educator, the middle lady there is Helen, our nurse consultant in infection prevention control. And then the person on the right is Amy Leonard, a fellow educator as well. And we started the Gloves Are Off project. We launched it in May 2018, but I'll give you a bit of a background as to why we launched it in the first place. So in 2017, I noticed a number of different things were happening across our hospital. So the first thing that I noticed was that our hand hygiene audits weren't necessarily following what I would call a true audit trail, in that we were sending nurses off to their own wards to collect data on how well people were washing their hands. And with them collecting their own data, there's obviously a bit of a bias going on there. But also they were calling it a hand hygiene audit, but only really doing the data collection aspect of it. So myself and Helen got all of our infection control link nurses together, and we decided to completely change the way we audited across the trust. And we moved from collecting data every month to collecting data once a quarter. And we would start our days once a quarter, bringing them together, teaching them about audit and what really is audit and how you can use audit to make changes. And then we would kind of give them better tools around collecting the data, and then send them off to each other's areas so that we remove the bias of our hand hygiene audits. And when we ran our first day, we brought everyone back together and just really asked the question, you know, rather than just collecting the quantitative data of how often were hands washed and at which of our key moments, what was the reason why they sometimes weren't washed? And the overwhelming reason across the trust was that people were still wearing gloves at the moment that they should have performed hand hygiene. And so we really knew then that this was an issue across the trust and that we needed to remove inappropriate glove use. But we also then had the challenge that we had taught these staff about audit and that it could be used as a tool for change. And now we needed to role model it as well. So we'd listened to what they said, and now we needed to role model how that change could look. The other thing that we noticed is with our nurses, particularly doing back-to-back IV drugs, that they would sort of have slightly damp hands still, having washed them, and then they put them in gloves. And by the end of a 12-hour shift, they would have red raw hands. And so skin conditions were kind of a regular complaint within our occupational health teams. So we really wanted to monitor that and see how we could improve the health of our staff's hands. Helen had also just come back from a secondment with one of our unions, rewriting some governance work and advice on glove use and prevention of contact dermatitis, and updated the standards for infusion therapy as well. So we had a number of different factors going on there that nudged us in the direction that we really needed to do something about inappropriate glove use. So we said to our staff, okay, I think we've got 2 key changes here. We want you to risk assess when you're using gloves and aprons, but particularly around gloves. We did see some small changes with aprons at the time that we're going to build on over the next year. But we asked them to only really consider wearing non-sterile gloves if they were going to be exposed to bodily fluids or dealing with any chemicals that might cause harm to their own skin. And really the key with the initial change was around that focus, particularly of IV medications and administration. Our first step was to do a literature review. You know, we know what we're seeing in our own hospital now, but what does the literature say? And there were 4 key kind of points that we put across, both to our stakeholders initially and then to staff across the trust, that really made the case for why we were making this change. So this first one is about questioning again why you're wearing gloves and which type of gloves you should wear. So if you're wearing gloves to protect your patient, they need to be sterile, not non-sterile gloves. And staff had often gotten into the headspace of putting on non-sterile gloves, thinking it was the best thing for their patients. So we really needed to challenge that and say, you know, if you're doing a wound dressing, wear sterile gloves. And one of the key issues with this research had found was that actually our non-sterile gloves, you know, they're in a box on the wall quite often. We don't know how long they're there for. Sometimes the gloves fall out and a parent might put them back in the box, that kind of thing. And actually this piece of research showed that a lot of gloves are contaminated with bacteria and spore-forming agents. So actually your clean hands are cleaner than non-sterile gloves often. And then just a reminder of if you're wearing non-sterile gloves, it's to protect you from bodily fluids. So really thinking about that non-intact skin, mucous membranes, and that kind of thing. So that's why I wear non-sterile gloves. And then what this mirrored what we'd found in our own audits about actually non-sterile gloves had been seen to kind of be a part of cross-contamination. And you can pitch this in healthcare when someone potentially empties a catheter bag and then takes the urine off to the sluice, we call it in the UK, or the dirty utility. But they're still wearing their same gloves and touching door handles and things like that in the process. So just seeing that kind of cross-contamination as things happen, because we're not necessarily taking our gloves off at the points that we should do. Also, this last piece of research was in adults. So we'd love to repeat it in paediatric population, but we've definitely, since our project, had anecdotal feedback from families about it. But in adults, they very much said that patients feel uncomfortable when staff approach and care for them in gloves, because it makes them feel slightly dirty and when they're trying to perform those tasks. So our staff rightly challenged us, okay, if you're going to say, don't wear non-sterile gloves unless it's to protect me, what medications might I come across that I need to protect myself against? And so we kind of gave this guidance, and we kept it on principles. So any medication where you're going to come into contact with a bodily fluid, so a rectal medication, an eye drop, nose drops, that kind of thing. Any therapeutically active cream, so a nice moisturizer that I would apply to my patients won't necessarily affect my hands in a negative way. But if I'm rubbing in a steroid or something, then I should wear non-sterile gloves to protect myself and protect me from that absorption. And then with any kind of liquid hormones or cytotoxic medications, we wanted our staff's hands protected. So how should we implement it? We looked at this research and really kind of found the key papers that lent to what we were doing and why. We then held a stakeholders meeting, really kind of looking at the key people that we thought would challenge us the most and maybe have issues with the project. And we presented the research and what we wanted to do. And actually at that time, when we thought they would challenge us in a negative way, they pushed us to go further and really that was a good way of propelling this project, knowing that we had the backing of these stakeholders. And they included people like our central venous access team, our dialysis teams, our chemotherapy administration teams. So many people that would possibly think their patients were in a special category that maybe we shouldn't apply the project to, but they all gave us their backing, thankfully. And then in the March 2018, we launched a trainer. So for all ward managers, all educators, all infection control link nurses, we trained them in a package of what is the change and what are the principles that we want you to apply. We did that over a month, and not just teaching those staff, but going off and talking to our occupational therapists, our school, our porters, all sorts of different staff groups. We really spent time during these months just making sure we communicated as widely as possible. Then the following month, we asked everybody we had trained to train anybody that they came into contact with as well. And we were really lucky at how enthusiastic they were in doing that. Most of the time when you make a change like this, you might normally want to do it across one ward and see whether it has a positive effect. But we knew our patients often move between wards. And so what we needed to make sure is as they move between wards, parents weren't starting to consider practice to be wrong on one ward rather than another, and observing that practice. So we had to make the change across the whole hospital on the same day. And then to maintain that stability around it, we would have communications come out to the staff, both by attending meetings, having screensavers, all sorts of things, basically every 3 months, thanking them for their engagement with the change and just saying how well they were doing at maintaining it and what effect it was having on infection rates, on our hand hygiene, and on plastics. So this is where we were for the first few years. So actually this graph, you can see how we were before, and this is compared to our bed days, our total bed days. So you can see 2017, and then we launched in May 2018. So just here, you can see that we started a downward trend here. These spikes here sometimes correlate with things like us opening a new building and us sort of stockpiling gloves ready for an opening of a new building. So you always see a variation depending on what's happening clinically. And you see our downward trend here as we go until the point at which we hit the pandemic, here sort of February through, and then we don't have an A&E at Great Ormond Street, and so we have mostly elective patients. And so we actually saw a very different picture to most people during the pandemic and saw a massive decline in our patients and therefore in our glove use as well. And then this is what's happened over the sort of whole time. And if you look at the green line, that's our average. So this is before we launched the project. This is the step change as we launched it and how that continued. Then as we hit the pandemic, and actually this dip here is where the government took over ordering and procuring all of our PPE. And then we had the variations that you would see, and I think most hospitals saw with anxiety of staff changing. And then as we came out of the pandemic, we actually saw another step change down in our usage of gloves. And these Tyrannosaurus rex around the outside represent how we presented the data to our staff, because we're a children's hospital. And so we wanted to equate it not to London buses or taxis, but to something that meant something to the children and young people. And so we would equate our different tons of glove savings in T-Rex. And so it's in the period of this graph, we actually saved 12.3 T-Rex worth of glove. Worth of plastic. But if we look just at that first year we saved 21 tons of gloves and associated waste in a year. We made a financial saving of 100,000 UK pounds, and that was both in the procurement of the gloves but also in the disposal of them. And we also saw our staff have a decrease in their sore red hands, which was brilliant. And then from an infection control perspective, we saw our hand hygiene improve, but we didn't see any increase in infection rates associated with the project. So if anyone was going to implement a similar project, just a few sort of possible top tips, maybe think about what's your why. I know that I will do anything for a sustainability project, but actually the majority of our staff, our clinical staff, will really be thinking about the patients and how good it is for them and making sure that this is just advancing practice. If you're talking to the exec team, then maybe it's about finances. think about, have you got good baseline data so that you can encourage staff as a project goes on, that you're headed in the right direction and you're monitoring everything that you need to monitor. Think about who your stakeholders are, not just the people that will encourage you, but the people that will massively challenge you. And what are their value set? You know, what's going to engage them in your project and help, and just listen to them, listen to their thoughts, listen to their queries and worries about a project, because anything your stakeholders say is something that the wider staff group are going to challenge later. And it really helps prepare you for all of those questions. Who can help you introduce the project? I said right at the beginning, it wasn't just me, it was a number of us, and that really helped because we were coming at it from lots of different angles. And so that helped maintain our enthusiasm, but it also maintained our kind of clinical expertise around the project, because we could pull on each other's expertise. And then what other systems do you already have in place for the project? Thinking about how do you maintain it? So for instance, we could see the wards where this didn't work very well were places where they maybe took our PowerPoint presentations and just emailed it on to staff. Whereas the places it worked really well is where we were doing annual IV reassessments. And so they decided to reassess people's skills at the same time as introducing the project, and really challenge that muscle memory of just pulling out a pair of gloves at a certain time. So what systems do you have in place? Can you put this on your trust inductions, that kind of thing? And that certainly really helped us. And I think I'm going to stop there and allow some space for the other speakers, but thank you for listening.
Thank you very much, Nicola. That was a very insightful presentation. So without further ado, I'd like to introduce our next speaker, Daryl Quant, who will be talking about a baseline process at Fraser Health. So Daryl is currently the planetary health lead within Fraser Health Authority in British Columbia, and is working to embed planetary health across the health system. So he completed his master's degree in community health sciences at the University of Calgary, and completed his public health specialty training with the National Health Service in the United Kingdom, held the role of public health lead on climate change and air pollution within the Great Manchester integrated healthcare system before returning to Canada. So thank you very much for being here, and over to you, Daryl. You're muted.
Okay, there we go. Hi, is that up on screen? Great. Hi, everyone, and thank you so much for the opportunity to speak. That was great, Nicola. Really exciting learnings. We are at a different phase in terms of at Fraser Health, in terms of very much looking at the beginning of our journey, but we are excited to learn and move forward on this. Just for context, Fraser Health Authority is located in the province of British Columbia, Canada, on the west coast, serving about 2 million people, 13 acute care facilities, as well as many other services that we provide in our area. Just to note that Fraser Health provides services on the traditional, ancestral, and unceded territories of the Coast Salish and Inklepamak nations, as well as 6 Métis chartered communities, and particularly relevant for this presentation, that Indigenous peoples have been stewards and caretakers of the lands, waters, and ice, and leaders in ecosystem conservation in what is now known as Canada since time immemorial. And just want to also acknowledge the team in this project, our hand infection lead, and the hand hygiene co-op students who were wonderful at making this initial project happen. Just by a bit of context, Fraser Health recently included planetary health as one of 3 organizational commitments. That's been huge for us in terms of mobilizing action around this area. In support of that, we recently had our planetary health strategy approved, which includes 4 focus areas: reducing the impact of our services on the planet, which is particularly relevant, of course, for today's talk, creating a climate resilient health system, building our role as an anchor institution, and really changing the culture in our organization. So the objectives of our work was to identify an approach to observing and collecting data. So we're not at an intervention stage yet. We're just really starting to think about this, and as Nicola did, we're really thinking about connecting this with hand hygiene as an initial start. And of course, the ultimate goal, though, is to eventually start to mitigate the adverse impacts of glove use on the environment and identify opportunities for hand hygiene improvement. So what do? We engaged our infection control leaders and a group of co-op students who are our hand hygiene auditors. In this work, we let them know this is about the issue, why it's important to us, why it's part of our organizational objective. We developed an approach to document glove misuse. So there is software and a tablet that is used to collect data. So we looked at how we can, as seamlessly as possible, collect additional information on glove misuse. And we looked at auditing hand hygiene practices and glove misuse among healthcare workers in 13 acute care sites over a 2-month period. So our hand hygiene students, of course, as Nicola went over, got themselves up to speed on what is appropriate glove usage. And of course, use the WHO glove pyramid as a criteria for how they coded glove misuse in their observations. They found that 37% of hand hygiene misses were associated with glove misuse in terms of the donning of gloves and the removal of gloves. So that was an important piece of information for us. They identified 6 categories of glove misuse around cleaning items, non-aseptic procedures, grabbing and or touching objects, miscellaneous, so police, visitors, security, and transporting and assisting rehab patients. They also noted, of course, the improper glove misusage, like double gloving, washing glove for reuse, or storing glove in pockets, and so on. The top misuse item was around non-aseptic procedures and using that. So we were able to actually get data around where we might want to initially focus our areas. And next steps is looking to update our official guidance to reflect planetary health concerns and note the glove misuse criteria. We've got different guidelines for different areas, and we want to try to look to standardize them wherever possible and get a consistent messaging across. And of course, compiling and familiarizing the health and safety protocols for different healthcare occupations and settings. Look at developing pilots for interventions on more fast-paced units and units with less body fluid exposure. And relevant for this project, really trying to establish that approach to measure reductions in glove usage. We're just starting to look at our purchasing data and understand that a bit more and connect that in with this work. So, as I said, we're very much at an early stage, but excited to have started the conversation around this and started to think about what we can do going forward. Thank you.
Thank you very much, Daryl. Our next and final speaker will be presenting in French, so I will introduce her in that language, allowing some time for the English-speaking people from the audience to change their caption settings, and I will change mine. Je viens de changer en français. Alors, Dr Sandy Perrault, présente ici, est médecin psychiatre et travaille à l'hôpital Charles-Lemoine depuis 2015. Elle est membre de l'Association québécoise des médecins pour l'environnement et a complété le programme de formation en plaidoyer et de mobilisation de l'Association canadienne des médecins pour l'environnement. Elle est présidente de l'éco-CMDP du CIS de la Montérégie-Centre depuis juin 2022, un comité qui vise à améliorer la qualité des soins en réduisant l'impact environnemental du système de santé. À vous, Dr Perrault.
Merci Sarah. Alors, je vais tenter de vous partager mon écran. Est-ce que vous voyez mon écran actuellement?
Oui, mais pas en plein écran.
Merci Sarah.
Oui, merci.
Alors, je vous remercie beaucoup de l'invitation. Je vais vous parler d'une campagne québécoise pour une utilisation appropriée des gants. Donc, en fait, ce qui est particulier dans notre campagne, comparativement aux deux précédents présentateurs, c'est que c'est une initiative de professionnels de la santé, donc, et non pas d'une institution de santé ou d'un hôpital ou d'un regroupement d'hôpitaux. Donc, c'est les professionnels de la santé eux-mêmes qui ont vu ce qui se faisait ailleurs et qui ont voulu se regrouper ensemble. Donc, on a eu plusieurs rencontres et on s'est trouvé d'abord un slogan qui est « Les gants, pas tout le temps ». C'est un travail qu'on a fait en collaboration avec Cascades Canada, Synergie Santé Environnement, l'Association québécoise des médecins pour l'environnement et le Réseau d'action pour la santé durable du Québec, qui ont tous contribué financièrement pour permettre de rémunérer le travail du designer graphique qui a fait l'affiche de la campagne. La campagne elle est soutenue par l'Association des médecins d'urgence du Québec, Choisir avec soin Québec, les médecins francophones du Canada et l'Association canadienne des infirmières et infirmiers pour l'environnement. Donc, en ce qui me concerne, j'ai aucun conflit d'intérêt de nature financière. Toutefois, j'ai des conflits d'intérêt de nature idéologique. J'ai une implication bénévole en tant que membre de l'Association québécoise des médecins pour l'environnement. Et comme Sarah le disait tout à l'heure, je suis présidente de l'éco-CMDP de mon CIS, dont le mandat est d'améliorer les soins en tenant compte des impacts environnementaux. Alors, si vous êtes ici, c'est que vous savez, tout comme moi, que les plus grands déterminants de la santé sont les déterminants écologiques, suivis des déterminants sociaux et structuraux, et que notre système de soins de santé ne représente au maximum que 20% de la santé des individus. Donc, c'est important qu'on s'assure que ce 20%-là ne vienne pas affecter les autres grands déterminants de la santé de la population. Parce qu'actuellement, notre système de soins de santé n'est malheureusement pas du tout éco-responsable et est responsable d'une grande proportion des émissions de gaz à effet de serre. Et ça affecte donc négativement les changements climatiques, ce qui augmente les pressions sur le système de santé en détériorant la santé de la population. Donc, on doit sortir de ce cercle vicieux-là au plus vite. Donc, comme je vous disais, c'est un groupe de travail multidisciplinaire qui s'est organisé. Donc, je vous fais ici la description là, des membres qui ont participé au groupe de travail. Donc, on a des médecins spécialistes en santé publique, des urgentologues, des médecins de famille. On avait 2 médecins microbiologistes qui travaillent dans leur groupe de prévention des infections, une psychiatre, en l'occurrence moi-même, une pneumologue, une anestésiologiste et une pharmacienne. Et on avait aussi la coordonnatrice régionale de Cascades Canada, donc Sarah McCain, la directrice et la coordonnatrice principale du Réseau d'action pour la santé durable du Québec, la directrice de santé synergie environnementale, la coordonnatrice de l'Association québécoise des médecins pour l'environnement. Et on avait aussi un contact au sein du syndicat de la CSN et une coordonnatrice au secteur de l'action sociopolitique de l'Alliance du personnel professionnel et technique de la santé et des services sociaux, ainsi qu'une conseillère sociopolitique de la FIC. Ce qui est intéressant aussi, c'est que en plus de venir de différentes spécialités, les gens venaient de différents endroits à travers le Québec. Donc, je vous ai mis la liste des régions, là, donc du Bas-Saint-Laurent, Capitale-Nationale, la Mauricie, l'Estrie, plusieurs endroits sur l'île de Montréal, l'Outaouais, l'Abitibi, la Côte-Nord, la Gaspésie, les îles de la Madeleine, Chaudière-Appalaches, Laurentides, la Naudière, Laval, la Montérégie et le Saguenay. Donc, pour amorcer notre travail, on s'est inspiré de la pyramide des gants de l'OMS. Donc, on a commencé par traduire là, la pyramide en français et travailler autour de ça pour créer une affiche. Donc, voici le résultat final de notre affiche en français. Donc, vous voyez notre slogan « Les gants, pas tout le temps ». Ensuite, vous voyez les encadrés qui précisent quand les gants doivent être portés et quand les gants ne sont pas nécessaires, donc quand ce n'est pas attendu qu'on en porte. Et on a 2 encadrés dans le bas, un sur les impacts environnementaux et un autre sur l'importance de l'hygiène des mains. Tout en bas, vous voyez un code QR qui relaye au site web de Cascades Canada sur lequel il y aura une vidéo sous-titrée en français pour donner plus d'informations sur la campagne. On a aussi une version en anglais de l'affiche pour les centres où il y a une clientèle bilingue. Maintenant, je vous détaille rapidement là, les indications pour le port des gants. Donc, comme ça a été dit tout à l'heure pour l'exposition aux liquides biologiques, il est à noter que les microbiologistes là, qui participaient au groupe nous ont précisé que l'exposition aux larmes, au lait maternel et à la sueur ne nécessite pas de porter des gants. Donc, ce ne sont pas considérés comme des liquides biologiques au sens du port des gants. Donc, quand les soignants ou les patients ont une peau non intacte ou quand il y a un contact avec des muqueuses, quand il y a une manipulation de produits toxiques, pardonnez-moi, et quand il y a une présence de pathogènes hautement infectieux et dangereux. Maintenant, quand les gants ne sont pas indiqués, donc je vous donne certains exemples, mais il y en a plusieurs autres, donc notamment pour la prise de signes vitaux, pour les injections sous-cutanées ou intramusculaires, pour la distribution de médicaments et de cabarets, pour la mise en place de l'oxygène ou pour l'habillage d'un patient. Il faut juste se souvenir que par contre, l'exception, c'est pour les patients qui sont en isolement contact, donc que ce soit pour le cycle difficile ou des bactéries multirésistantes. Maintenant, ce qu'on aborde sur la fiche et dans notre campagne, c'est les risques liés à la surutilisation des gants. Donc, entre autres, le gaspillage de ressources, sans pour autant contribuer à réduire le risque de transmission croisée. Aussi, le risque de non-observance lors des opportunités à l'hygiène des mains. Donc, encore une fois, comme ça a été dit par les précédents présentateurs. Et l'usage des gants à des moments inopportuns qui peut être à l'origine de la transmission de germes. Donc, ce qui est important de savoir, c'est qu'au Québec, les groupes de prévention des infections sont vraiment des entités qui sont locales, donc qui sont la plupart du temps par centre intégré de santé et services sociaux. Et ils ont pas toujours les mêmes recommandations et malheureusement, souvent, ces recommandations-là ne sont pas nécessairement adaptées en lien avec les recommandations de l'Organisation mondiale de la santé. Et trop souvent, ce qu'on remarque sur le terrain, c'est que l'application de ces conseils-là n'est pas nuancée. Donc, les soignants ont tendance à avoir le réflexe de protection au cas où. Donc, ça nous mène à une surutilisation des gants. Et ce qu'on veut faire ressortir par la campagne, c'est que l'intention des gens, elle est bonne. Quand ils surutilisent les gants, c'est pour se protéger, mais ça ne les protège pas. Et ça les met même plus à risque d'avoir des infections ou des dermatites de contact. Donc, c'est nuisible pour leur santé à eux, en plus d'être nuisible pour la santé planétaire et donc celle des populations qu'on soigne. On est rendu maintenant au défi de la diffusion de la campagne. Donc, étant donné que c'est pas via une organisation comme telle, mais plutôt par différents soignants et soutenu par différents organismes, on a certains CIS et CIUS qui ont déjà accepté d'emblée de diffuser la campagne via leur communication. Donc, pour eux, ça va être un petit peu plus facile et il faut savoir qu'il y a la possibilité d'imprimer l'affiche et de la diffuser dans tous vos lieux de pratique respectifs. Donc, il n'y a pas de droit d'auteur sur l'affiche, c'est libre d'accès. Le but, c'est justement de la diffuser pour sensibiliser le plus de membres du personnel soignant possible au Québec. Donc, voilà, ça fait le tour de ce que je vais vous présenter. Donc, je vais être disponible pour la période de questions.
Merci beaucoup, Dr. Perrault. Je vais maintenant changer ma langue à l'anglais. So thank you very much to our 3 speakers today. We have some time to answer questions. So you have the option of asking questions in the Q&A section of your Zoom window or in the chat. So we have one question in the Q&A that hasn't been hasn't got an answer yet. So hello everyone, this question goes out to the three presenters. Sorry, I need to leave this meeting at 11:30. In Quebec, the Association for Workers has a document that requires healthcare workers to use gloves when handling medication, the patient's body fluids, and contaminated sheets and areas. Your poster contradicts this best practice. So I don't know if the person is still here and can talk about the poster in question. But the more global question, I think, is how do you deal with potential contradiction in your healthcare setting within this campaign?
En fait, je peux essayer de répondre du mieux que je peux. Premièrement, la médication, moi je travaille en psychiatrie, donc je peux parler de ce qui touche ma spécialité. Les médicaments sont servis dans des petits sachets en plastique et la meilleure pratique, c'est de remettre le sachet identifié avec le médicament officiel au patient. Donc, que lui-même déballe le sachet et prenne la médication, ou encore la lui donner dans un petit cup de papier, ce que plusieurs infirmiers et infirmières font. Donc, à ce moment-là, ils ne touchent pas le médicament d'aucune façon. Donc, c'est vrai que sur nos profils pharmaceutiques, il y a quelques médicaments qui sont étiquetés comme étant nécessaires de porter des gants pour les manipuler. Ceci étant dit, mis à part l'acide valproïque ou certains médicaments de chimiothérapie, bien entendu, la plupart de ces recommandations-là, dans mon CIS, ne sont pas à jour. Ça a été discuté avec les pharmaciens, que trop souvent, il y a des indications qui disent qu'on devrait mettre des gants pour les manipuler, mais ce n'est pas vrai, ce n'est plus à jour. Donc, c'est juste que les recommandations n'ont pas été mises à jour, comme ça arrive trop souvent.
Thank you very much. I see another comment in the chat section that it's on the poster. That gloves are needed when manipulating toxic products.
I would probably, sorry, I was just going to say, I'd probably say the same thing. You know, there's absolutely still times when gloves are appropriate, and certain medications that you do need to protect yourself from. So it depends on what poster and what their key point is there. We definitely had the issue with some of our images that were around our hospital at the time that we launched, in that still old posters were around that showed people in gloves preparing IV medications and things like that. So it does take a while to change those kind of things that stay with an organization for a while. But also we have had the challenge, as many did during things like COVID, where maybe our government was recommending certain infection control precautions that didn't necessarily seem logical at the start of the pandemic, but we very much had to follow what government was saying, and were very relieved when things came back to a more normal. So sometimes the information that's out there is questionable, but it depends what source and how you have to go along with it or not.
Thank you. So I see in the chat, someone said, in short, it's normal to find incoherence within the institution. So do we need to update our written procedures and visual documents? Yes. So next question. Why was Quebec's use of PPE from March 2020 to April 2022 over 3 times the amount of Ontario's PPE usage? So I think the data is from the Canadian Coalition for Green Healthcare study. So I don't know if there's someone here from the coalition who could interpret this data, or I can link, I can put the link to the study in the chat.
Yeah, please add the link, Sarah. And unfortunately, Linda Yarangu, who was the lead on the study, is not with us today. But I'm also happy to put Joshua in contact with Linda as well, if you have additional questions on that.
Thanks, Adam. So I'll put the link in the chat as soon as I find it. When you notice that gloves purchases had gone down, could it be because of staff, once they put gloves on, they do not remove? So is it because of the an issue with glove removal?
Guessing that one's to me. It might not be. No, because we also carried out our hand hygiene audits at the same time. So we could tell that they were removing them. When they were wearing them appropriately, they were removing them for hand hygiene more appropriately. So it wasn't that they were keeping them on and wearing them all day, or for multiple contacts.
Thank you, Nicola. Next question. Cleaning and disinfecting products to clean bedside tables and bed rails are often cytotoxic. They also require the use of gloves. Do you know of any initiatives to change this? For example, a transition to more organic-based products?
I don't know if anyone else wants to answer that one. We've certainly, the wipes that we use in our hospital, we contacted the company as in our initial stages to see if they needed us to wear gloves whilst using them to wipe. And they said no, that wasn't one of their hazards and that they were safe to the skin. So we were fortunate in that sense, but they are, are not daft to the fact that these are still plastics. All of our wipes are plastics. And our Royal College of Nursing is currently doing some work with our Environment Agency around the hope that we will at some point remove wipes from healthcare. So we're following that very, very closely to see how we can mimic that and bring about any changes that they theoretically or within research find, and how we can help them implement those practically.
Thank you very much. I don't see any other questions here. Maybe a comment for the question about Quebec. It could have something to do with the type of purchases during the pandemic. So centralized with the government or individual institutional purchases like in the UK. I'll leave maybe a couple of minutes to see if we have additional questions.
There's somebody that has asked about they apparently work in a pediatric emergency department, and so most of their children are classified as having a respiratory illness, and it appears, I think from this question, that the hospital's asking them to wear gloves even if doing a history. And is there evidence that this is needed when we're not coming into contact with bodily fluids? At Great Ormond Street, that we certainly wouldn't advise someone to wear gloves in those circumstances, because even if the person has got a respiratory virus, a known respiratory virus, the risk is if you're wearing gloves, you're going to carry that out with you, or touch all of the different kind of associated surfaces in the room and actually move that bug around with you, that virus or bacteria. So what we would say is go in that room and make sure that you wash your hands in between different aspects of care, but also before leaving the room. That would be our advice, that your clean hands are always safer.
Thank you, Nicola. Is there an opportunity to recycle the used gloves?
I can maybe try to take that one. We did look at if there was an opportunity to recycle gloves, but the best way is to reduce the use, because even if we recycle them, there's an environmental impact, and it's not the best way to deal with the issue.
Yeah, go ahead, Nicola.
Well, no, I would just absolutely second that. I think our understanding of plastics is really in its infancy in healthcare, and the way that they're recycled. And certainly we use a lot of plastics and have to add various polymers to them to make them efficient within healthcare. And as soon as you start recycling them, you're breaking down those chains and those polymers. You're not only making microplastics, but you're also making something unstable that could then be absorbed by the body in a different way. So I'd be very cautious of that.
Yeah, just echo Nicola's statement that reducing is the best way. There is in British Columbia PPE recycling. I'm not sure if that actually includes gloves or not, and I know there's been talk about biodegradable gloves, but there's issues about whether they would have the oxygen needed in a landfill. So again, it's a lot of just wherever possible, getting to the top of that pyramid of reducing it is where we want to focus our efforts.
Thank you. There are some initiatives in Quebec as well. Maybe for the next question, and there's a link between two questions. How did you engage infection control practitioners that love their gloves? That links to pourquoi la PCI n'a pas été impliquée dans le comité de travail. So maybe we can answer the first question as a group, and then we could see for Quebec. So the question was, sorry, how did you engage infection control practitioners?
Well, for me, I started the project with our infection control nurse consultant. So I started right at the beginning with the right person. And thankfully, she was on board because she'd read the research. And so I was really lucky that that helped lead the project. But I do know, I've probably had over 150 different organizations contact me, and many of them say their largest barrier is their infection control team. And in the UK, we now call it yellow washing because that's the colour that infection control are associated with in the UK. So I'm very fortunate that Helen, our infection control nurse consultant, anybody that struggles with their own team will reach out to them and have conversations with them, and try and lead from that perspective. So she's very open to questioning other people's research.
From our experience in Fraser Health, part of our having this as an organizational objective means that we're identifying planetary health leads from different areas. And so infection control was obviously an area that we wanted to identify a planetary health lead who could help us with barriers and challenges. And although we're at early stages so far, they've been fantastic at helping to make things happen.
Donc, pour ce qui est de la campagne québécoise, ce que je peux vous dire, c'est que, comme j'ai bien mentionné dans ma présentation, les comités de PCI sont vraiment locaux, donc dans chaque CIUS, et nous, on voulait faire une campagne pan-québécoise. Donc, on ne pouvait pas consulter chaque PCI de chaque CIUS, ça aurait été beaucoup trop fastidieux. Toutefois, on a sur notre groupe de travail 2 microbiologistes, donc qui sont, eux, impliqués dans leur PCI, dans leurs CIUS respectifs, et qui ont l'expertise pour tout ce qui concerne la prévention des infections. Donc, on peut dire qu'on les a impliqués d'une certaine façon, puis que maintenant, avec cette campagne pan-québécoise-là, on veut faire redescendre l'information localement. Donc, ça va être les gens qui sont impliqués dans la campagne, dans chacun de leurs CIUS respectifs, qui vont aller parler avec l'équipe de prévention des infections. En fait, moi, pour ce qui est ma partie, je l'ai présenté à notre CDD, donc le Comité de développement durable, et l'infirmière de la PCI m'a invité à aller présenter au groupe de PCI. Donc, on va le faire en collaboration. C'est juste que ça n'a pas parti de eux pour différentes raisons. Mais oui, on va le faire en collaboration. Puis, j'ai beaucoup aimé le commentaire là, de Nicolas sur le yellow washing parce qu'il y a ce que la PCI dit, mais il y a aussi ce que les gens pensent que la PCI dit. Et ça, c'est souvent deux choses très, très différentes. Donc, c'est important de retourner à la source. C'est qu'est-ce qui est la réelle consigne et pourquoi. Je vous donne un exemple. Là, au début de la COVID, les gens étaient très, très anxieux, moi y compris, et les gens se sont mis à mettre des gants pour un petit peu tout et rien. Et nous, en psychiatrie, des fois, on a des patients qui sont un peu agités, donc il y a une équipe d'intervention qui va auprès des patients. Et depuis le début de la COVID, tout le monde se met des gants pour les interventions. Puis, c'est comme 9 sur 10 des gens qui sont dans l'intervention ne vont même pas toucher le patient, donc ils vont encore moins toucher les liquides biologiques. Donc, c'est complètement absurde qu'on mette des gants pour ça. Mais les gens agissent beaucoup par mimétisme. Donc, aux interventions, c'est des préposés aux bénéficiaires, des agents de sécurité. Donc, il suffit qu'une personne en mette, que tout le monde en mette aussi. Donc, on a créé un sous-comité pour les unités d'hospitalisation en psychiatrie. Et on va faire comme un focus group là, pour voir pourquoi les gens mettent des gants, puis quel est le rationnel derrière ça, et adresser leurs inquiétudes s'ils en ont pour viser à changer cette pratique-là qui n'est pas conforme.
Merci. Question for Nicolas. How did you get the input from the patients?
So initially, our communications team at the hospital actually told us not to highlight the change through posters or information sheets to our patients, because that was one of our first things. We sort of said, you know, how many different languages will we have to have this in and everything else. And their rationale for not highlighting it was that you're almost highlighting that your practice wasn't excellent before the change. And so just what they encouraged us to do was make sure that every member of staff was equipped to answer any questions that a patient or family had. So that's what we did, and that's why we really stuck to key principles with the project about only wearing non-sterile gloves if you're coming into contact with bodily fluids or a chemical that could be harmful to your hands. And we really kept to those key principles to make it really easy for staff to relay that, and to those kind of key research points as well. But latterly, what we then did do, and Helen actually particularly was excellent at this, is she would go and sit in patients' rooms and talk to parents, and sort of ask what their experience was of the project. And they said, if anything, we're just seeing our nurses and other clinicians wash their hands more. And so that anecdotal, although we didn't take that as a survey, we did certainly talk and listen to a lot of families, and that anecdotal evidence was just really such a relief to hear.
Thank you, Nicola. Question from Emma Burns. My institution's infection control will definitely have an issue with not using gloves when even entering a room. Do you know of an evidence compilation I could use to speak to them to try and argue the case?
Yeah, certainly. I think if my slides are shared, then at the end I've got my reference list, so that can certainly be used. And if not, anyone can email me and I will send them out any of the resources that we used.
Thank you. So I think that we've answered hopefully all of the questions. So maybe we could stop the webinar here. Thank you very much to our panelists and speakers. And I'll leave you, Autumn, for the closing remarks. Thank you all.
And thank you so much, Sarah, Sandy, Nicola, Daryl, for being here today. We really appreciate you coming out to speak on this very important, very relevant topic right now. And thank you to all of our attendees. Again, I will be sending out the webinar recording later today or tomorrow, which you are welcome to share with friends, colleagues, share it widely. So thank you again, and enjoy the rest of your day, everyone.